Hello, everybody. This is Rob Pass, the host of the podcast. This week, we're taking a step back in time to review an episode with Dr. Tony Pastor, who presently works at Baylor University. In this episode, Dr. Pastor reviews a recent report he and his colleagues at Boston Children's Hospital and the Bach program wrote on the topic of lower extremity vascular changes in the Fontan patient and possible association with worse outcomes. I hope you enjoyed this replay episode from just a few years back. Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm professor of pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you for joining me for this 242nd episode of the podcast. I hope everybody enjoyed last week's combined podcast with the PCICS podcast team, in which we spoke with Dr. Gil Wernovsky of Children's National Hospital about the upcoming exciting World Congress of Pediatric Cardiology and Cardiac Surgery. I'd recommend everyone take a listen to last week's episode to learn about all of the exciting things that are going to be coming to us in late August and early September of this year. As I say every week, if you'd like to get in touch with me, it's easy to remember my email. It's pediheart@gmail.com. This week we move on to an interesting research letter in the world of adult congenital heart disease. The title of the work we'll be reviewing is The Association of Lower Venous Disease to Outcomes in Adults with Fontan Physiology, CAF Revisited. The first author of this work is Tony Pastor and the senior author Anne-Marie Valenti, and this work comes to us from the Boston Adult Congenital Heart Program at Boston Children's Hospital and the Brigham and Women's Hospital. When we're done reviewing the paper, Dr. Tony Pastor, the first author, who is presently an adult congenital specialist at Yale University, has kindly agreed to join us once more in the podcast to discuss this work. Therefore, let's get on to this brief research letter and then a conversation with its first author. This week's work is on the topic of venous insufficiency in the legs of Fontan patients, and the authors begin by referencing a work from their own group 13 years earlier, which was the so-called CAF, or Congenital Heart Disease in Adults Lower Extremity Systemic Venous Health Study. And in that study, they showed that this problem of venous insufficiency was highly prevalent in adults with a Fontan, and also that the prevalence of severe insufficiency was 3 to 4 times higher than the general population. And they also reference a large-scale European study with over 12,000 adults, showing that having this level of venous insufficiency correlated well with enhanced mortality. With this as a background, the group in Boston wanted to know if in follow-up, this initial cohort, which is now 13 years old, had in fact had adverse outcomes. And this was the rationale for this brief research letter. This was a retrospective chart review study of the original 103 patients from Boston Children's Hospital to look at time from study enrollment to first outcome event. And for this work, the outcome events were all-cause mortality, heart transplantation, thrombotic or thromboembolic event, infectious conditions such as cellulitis or endocarditis, or Fontan infection. The median follow-up here was 11.3 years, and the age at enrollment in the CAF study was 28 years, with 50% being male, with an average age of Fontan of 7 years, so this is clearly something of a historical cohort. And how did this group do? Well, the outcomes aren't good. 30 of the 103 patients, or 29%, met the primary outcome inclusion criteria, with a median time to the outcome of only 3 years. And what were these outcomes? Well, there were 28 deaths, 20 thrombotic or thromboembolic events, 9 infectious complications, and 2 heart transplantations. In univariable analysis, the presence of venous insufficiency, older age at Fontan, and the type of Fontan, meaning old-style Fontan, as well as the use of diuretics and warfarin, were all associated with the composite outcome. In a multivariable analysis, adjusting for multiple risk factors, the presence of chronic venous insufficiency at baseline, whether mild or severe, remains associated with the composite outcome, with a hazard ratio of 9 to 9.5 versus the reference group who did not have chronic venous insufficiency. The authors review the prior work that they did on this cohort and how they previously demonstrated a high prevalence of chronic venous insufficiency in this group, and how this is likely due to the lack of pulsatile flow, influencing the loading conditions and venous pressures in peripheral veins, as well as possibly affecting endothelial function. They re-emphasize the association found in this study between chronic venous insufficiency and bad outcomes in the Fontan patient, and explain that this association that they've demonstrated should be a rationale for developing new therapies to mitigate venous insufficiency, and they wonder if this may improve long-term outcomes. They also suggest that if this sign is observed, it may potentially be seen as a rationale to invoke earlier therapeutic strategies, and they suggest possibly using compression stockings or even superficial vein ablation, and they explain that future studies assessing the impact of these therapies on the composite outcome are warranted. And so they conclude, as chronic venous insufficiency is an easily identifiable clinical finding, treatment of insufficiency may lead to more timely strategies for interventions aimed at reducing morbidity and mortality in Fontan patients. Well, I think some of you may be wondering why I chose to review a research letter this week, but really I do think that the message here is critically important. I think that those of us who care for Fontan patients, especially adult Fontan patients, have always imagined that it was not a good sign if we observed chronic venous changes in our Fontan patients. But this work really sounds the alarm of risk, and clearly shows that if you see this, your patient may be at substantially elevated risk for a bad outcome, and more aggressive assessment and possibly treatment might very well be warranted. Just what that treatment ought to be, however, is obviously not clear. Should we be treating the actual venous insufficiency, as the team in Boston suggests in their brief discussion, or should we be more assessing hemodynamics and seeing if there's more that can be done that might reduce risk? Or should we be doing both? At this point, therefore, I think it makes sense to move on to speak with the first author of this work, Dr. Tony Pastor. Tony Pastor is Assistant Professor of Clinical Pediatrics at Yale School of Medicine, where he practices adult congenital heart care as well as pediatric cardiology. He completed a combined residency in internal medicine and pediatrics at Baylor College of Medicine, and stayed on as the chief resident. He then completed a pediatric cardiology fellowship at Boston Children's Hospital, followed by senior fellowship in adult congenital heart disease at the Harvard Adult Congenital Heart Disease Program. During this time, he received additional training in advanced congenital cardiac imaging. His research interests include utilizing cardiac MRI to further risk stratify and improve outcomes in patients with congenital heart disease, as well as the intersectionality of LGBTQ+ health and congenital heart disease. Tony is also a former guest on the podcast, and we are delighted to welcome back to discuss this week's work. Welcome, Tony, back to the podcast. I'm here now with Dr. Tony Pastor. Tony, thank you very much for joining us once more on the podcast.
Oh, thanks so much. It's a pleasure to be here.
Thank you. A lot of buzz about you coming. I think you have more friends in congenital heart world than just about anybody, so thank you very, very much. Tony, very much enjoyed this research letter. And, for those of us in the audience who are more pediatric-oriented, I'm wondering if maybe you could share with us, why do people develop chronic venous insufficiency in the first place, and why do you believe it's more prevalent amongst Fontan patients?
Sure, absolutely. So chronic venous insufficiency is a pretty complicated disorder. And like most complicated things in medicine, the cause is always multifactorial. So what we do know about this particular disease is that it's a combination of venous valve incompetence that leads to venous reflux. Hormonal changes in pregnancy, for example, can lead to it. Inflammatory changes in the vessel wall. And then there's hemodynamic factors like obstruction and DVTs or deviating thromboses that can lead to venous hypertension. And all these factors can sort of play a role in the development of chronic venous disease. Not everyone has all of them. In the general population, for example, the biggest risk of developing it is advanced age, obesity, having a family history of chronic venous disease. But in Fontan patients, what we do know about the pathophys, it's less so due to actual obstruction of the veins. So there was a nice study that was done in 2013 with Dr. Bott, Dr. Valente, and they basically ultrasound all these patients, and they found no obstruction, but they ended up finding a lot of venous reflux in the studies. And probably the more interesting thing about that study is that even patients without skin changes in the cohort actually had venous reflux as well, about 50% of them. So it's probably starting even earlier than we actually see it physically.
Wow, that's a little frightening. You know, Tony, your
Yeah.
work showed in univariate analysis that the use of diuretics or even warfarin was associated with the composite really bad outcomes that you describe in the work. To me, diuretic use would seem to make sense given that a patient needs a diuretic maybe would be a marker for someone who has worse hemodynamics. But I'm wondering if you might be able to posit for the audience a reason for why warfarin use was more associated with poor outcomes also.
Yeah, I think initially that was a bit of surprise for us as well. But if you like, bear with me, if you sit here and think about it, about the natural history of a lot of our adult Fontan patients, and you also have to kind of consider the typical practice patterns in pediatric cardiology. So for the most part, our Fontan patients start off with aspirin as a child, right? And then as they transition to adult congenital, sometimes they may have a clot, sometimes they may have atrial arrhythmias, and for whatever reason, we end up transitioning them either to Coumadin or DOAC. And what we know about these sort of larger cohort studies of Fontans, like in New Zealand or Australian registries, we know that the onset of atrial arrhythmias has been shown to be an independent predictor of late failures. So maybe a bit of a stretch, but I guess when I think about this, our study, I think of, in the case of the Coumadin being a predictor, it may more reflect worsening hemodynamics and a decline in the circulation as a whole. But I can't prove that to you 100%, unfortunately.
So you're basically suggesting it's a marker of people who need it for even other reasons that we know are associated with bad outcomes in Fontan patients.
Yes, exactly.
I see. You know, I thought it was interesting that in your work you commented that efforts to treat or even prevent venous insufficiency might potentially improve outcomes. I wondered if you thought that the insufficiency is the cause of the bad outcomes, or rather it's just a marker of a worse hemodynamically embarrassed Fontan.
Yeah, it's a good question. It's the old chicken or the egg
Exactly.
dilemma. And I wish I knew exactly, but is it possible that chronic venous insufficiency, similar to like protein losing enteropathy, is more symptom of Fontan failure, and that if there's an anatomic substrate that we can go and we can fix it, we can decrease Fontan pressures and improve symptoms? And the answer is maybe, but I guess I'm not totally convinced that's the case. And the reason I say that is that we know, there are, some studies in Fontan circulation that, these patients have decreased skeletal muscle mass, particularly in their lower extremities, and that without a subpulmonary ventricular pump, lower extremity muscle contraction is probably a big driver of venous return and cardiac output. And we know that patients who have higher muscle mass and have increased preload, increased cardiac output augmentation during exercise, and increased peak VO2. So I think one could almost argue that, it is very possible that we're missing a very vital part of Fontan circulation, and we shouldn't just think of the circulation as stopping at the IVC or the hepatics, that there may be things that we can do to the distal vasculature that can improve patients' overall cardiac health. But I think we just need to study it.
I see. Well, sort of following up on that question, Tony, what kinds of therapies would you recommend for venous insufficiency in this patient group? Is it worth it, for example, to do all these various varicose vein treatments like ablation, or if the cause of the deranged hemodynamics still exists, or do you think there may be separate benefits from directly affecting these veins that are deranged, like, I don't know, I'm just making up something. Does it reduce infectious complications, for example?
Yeah, I think it's really hard to recommend a particular strategy without studying in this patient population, but I would say that, that original study that showed that like 49% of Fontan patients had venous reflux even before seeing skin changes or chronic venous insufficiency changes on exam, that if we're going to do something, that we probably should do it pretty early. And, maybe we should be treating pediatric Fontans more aggressively with exercise routines as a child that sort of promote lower extremity muscle growth, preventing them from getting to these stages where we see varicose veins, skin changes, stasis might be the best intervention. I think when they get, I mean, let's face it, treatment for chronic venous insufficiency is really hard to tolerate. Compression stockings are not always the most comfortable. They can be expensive. Insurance doesn't pay for them all the time. So, if we could do something earlier on, that might be better. If you're at the stage where you are having, skin changes and you're thinking about compression stockings and sclerotherapy and pneumatic compression devices, I think it's worth sending them to a vascular specialist early on, because we could actually, prevent things like infection or improve their, edema on exam or potentially their overall exercise tolerance. But like I said, we sort of need to study that in a systematic way.
I see. Well, for those in the audience, it's fairly late on Monday evening before the podcast is coming out, so I'm going to finish this interview up with you, Tony, with my last question, which is the million-dollar question, which is, when you meet a Fontan patient who has chronic venous insufficiency changes, what is your workup for such a patient, and is it different than for other Fontan patients? For example, if you see chronic venous insufficiency changes, would this, in your mind, for example, warrant a catheterization or maybe other forms of imaging that you might not otherwise recommend in such a patient?
That's a very good question. It's funny, as somebody who does like cross-sectional imaging, I'm already getting the reputation at Yale of the person who's ordering all these MRIs and CTs on our Fontan patients. But I think there's a reason the 2018 ACHD guidelines recommends this. And cross-sectional imaging can be quite helpful for our Fontans. And in my brief time of being here, I've seen a lot of our Fontans have a significant degree of chronic venous insufficiency on exam. And I have been ordering more MRIs and cross-sectional imaging as an initial sort of screening. And I've sent a lot of these patients to the cath lab for Fontan conduit narrowing or pulmonary artery stenosis, et cetera. I think the big question that needs to be answered is that by doing that, by being more aggressive, especially if they're relatively asymptomatic, are we changing the natural history of their circulation and ultimately their outcomes? And I think an even bigger question is, should we be using traditional or novel therapies of chronic venous insufficiency in addition to sending them to the cath lab? I haven't quite figured out what's the best way to study that quite yet. But I'm kind of wondering if there are patients that don't have any particular anatomic substrate in their Fontan pathway that we can see on imaging that might be a good cohort to sort of study for that particular intervention.
Yeah, great answer there, Tony. I mean, I think this is going to be a very hard topic to study because of the extraordinary anatomical variability in these patients. And, so many Fontan patients, for example, have a small left pulmonary artery, and we've lived with those for years and years. And usually by the time we identify it in the ACHD patient, stenting it is of unclear benefit, and so it'll be I think it's probably going to take a long time until we figure this all out. But I certainly agree that this finding, certainly you guys have demonstrated that if you see this in a patient, you ought to be pretty worried about your Fontan patient, for sure. Well, Tony, I can't thank you enough. You're one of the rare guests who's been on the podcast more than once. And in fact, you're also one of the rare guests who's had a family member actually be our musical guest. So this week it will not be your husband, but I do want to thank you. And I want to thank your husband for allowing us to play his music on the last time you were on. And I wish to congratulate you and all of the many co-investigators in the Boston Adult Congenital Group who were behind this project.
Thanks so much. Absolutely. Really appreciate being here.
Pleasure. Well, I think you'll all agree that Dr. Pastor shared with us many of his thoughts about chronic venous insufficiency, and I definitely feel as if I have a better understanding about this problem and the potential risks associated with it, not only for the Fontan patient. It seems clear that the jury is still out regarding the optimal means of managing this, but it seems similarly clear that more aggressively investigating these patients will be an important first step in trying to better understand this pathophysiology to improve outcomes. Similarly, it's also increasingly clear that emphasizing lower extremity muscular strength, as suggested by Dr. Pastor, echoing concepts that have been espoused by Jack Rychik, is likely also important. I'd like to thank Tony once more for taking time out of his very busy schedule to speak with us this week. To conclude this replay episode of Pediheart Pediatric Cardiology today, we hear the famous aria from the Czech opera Rusalka, written by Dvorak, and the aria is entitled The Song to the Moon. In this beautiful music, the lead character of the opera, Rusalka, who is a water nymph, falls in love with a mortal man and prays that he will love her also. Today we hear the wonderful up-and-coming Armenian soprano Juliana Grigoryan sing this aria in a live competition performance from just a few years ago. Thank you very much for joining me for this replay episode, and thanks so much to Dr. Pastor. I hope all have a good week ahead.
So